Well, it's a pleasure to be here, and I feel honored to start off the meeting. We're going to jump into the clinical history on the patient. This lady was a 68-year-old woman who had been followed for some time by a cardiologist at an outside hospital. And she'd been complaining of progressively increasing fatigue and shortness of breath. And the reason that she came to our attention was a worsening echo and worsening history. She had repeated episodes of dizziness and actually had a couple of syncopal events, one of which was when she was driving her car, resulted in a serious car accident. And her echocardiogram, surface echo, was remarkable for elevated velocities within the left ventricular outflow tract, as well as an increasing gradient. And you can see that her peak gradient was greater than 75. Her mean gradient was trending toward 40. The more concerning finding on echo that prompted evaluation for surgery, though, was increasing aortic insufficiency, and we'll talk more about that. So this is just a sampling of some of the axial images from her cardiac gated CT, and what I'm doing is going back and forth within the left ventricular outflow tract, which is right here. And the first thing to note is that the left ventricular outflow tract is generally narrowed, and that's related to some asymmetric basal septal hypertrophy. But I'll draw your attention to this little tag of tissue right here, and we'll see that more on the upcoming images. So again, this is the left ventricular outflow tract. This is the little tag of tissue that was of interest. And on the intraoperative transesophageal echocardiogram, which is displayed in the upper right-hand corner of the image, you can see two things. You can see that the high velocity turbulent flow is not emanating from the aortic valve itself. It's actually emanating from right below the valve during systole. And during diastole, when the valve is closed, you can see that there's an insufficient jet going back into the left ventricular outflow tract. Down here in the lower right corner is basically a 3D volume rendered image of the heart. It's in the same orientation as the image above, for simplicity's sake. So the left atrium is the echolucent chamber at the top here on the echocardiogram, and here's the left atrium in this image down here. And what I've done is I've inverted the blood pool. In other words, instead of the blood being high attenuation and impossible to see through, I've just not rendered it. So you can actually see inside of the heart. And this is the left ventricular outflow tract again. And if you look, you can see a ridge of tissue here, which is a fibromuscular membrane, just below the level of the aortic annulus, about a centimeter below. So just to review those echo images again, during systole, you've got the high velocity jet with turbulence and aliasing emanating in the left ventricular outflow tract instead of at the level of the valve itself, and the insufficient jet during diastole. So the diagnosis was one of membranous subaortic stenosis. There's two main flavors, if you will, of subaortic stenosis. There's the discrete membranous variety, which we're discussing here, and then there's also the tunnel type variety, where there's more of a generalized muscular narrowing of the left ventricular outflow tract. Oftentimes there's a combination of the two, as in this case. It's a poorly understood abnormality. Most people believe that it's developmental with a probable genetic linkage. But some studies have shown that there's a relationship with prior surgeries. And there's a common association with a variety of different cardiac abnormalities. The most typical is one of a VSD. There's also bicuspid aortic valve, quadricuspid aortic valve. One study had reviewed a series of 72 patients. And in those 72 patients, they found 2 patients that had quadricuspid valve, which is way out of line with the typical incidence of that developmental abnormality. It's also commonly associated with abnormalities of the aorta, coarctation, hypoplastic ascending aorta, and interrupted aortic arch, and is also sometimes associated with a small aortic annulus at the aortic root, and I'll actually show you that in a companion case in just a minute. But so here I'm inverting the blood pool and going into that left ventricular outflow tract, and you can see as I change perspectives how this little membrane here would narrow the outflow tract. And you can imagine that if you cut the aorta here and look down through the valve, you would see this picture right here, which is in the lower left, and this is what they saw at surgery. So again, this membrane is a fibromuscular membrane. It's oftentimes thought of as a benign tumor, if you will. It shows progressive growth and eventually will obstruct the left ventricular outflow tract and result in symptoms. The jet in the left ventricular outflow tract, this narrows it so you get high velocity going through the left ventricular outflow tract, and that jet will impact upon the undersurface of the aortic valve. And this causes a premature degeneration of the valve. The valve will thicken, the leaflets, as they become sclerotic, may stenose slightly, but more important, the free edges of the leaflets tend to retract, which results in a central area of malcoaptation and results in progressively increasing aortic insufficiency. Also, because of the consistent damage to the endocardial lining of the valve, you develop, or the patients are prone to a higher rate of endocarditis. The treatment is resection. They used to, in the past, do a sharp resection, but they tend to try and enucleate these things. In other words, they grab it in block and pull on it, and it tends to kind of shell out from the adjacent tissues. Sometimes, though, if there's a muscular narrowing as well, they have to do a septal myectomy as well. That increases the risk for surgical-related complications. The indications for surgery are obviously if the patient has symptoms, and the symptoms that we typically look for are similar to those with aortic stenosis. So worsening CHF, angina, syncope, and decreased exercise tolerance. But sometimes in patients who are asymptomatic, particularly in younger patients, this patient was somewhat atypical because she was older. Usually in younger patients, they're going to be looking for the elevated pressure gradient across the membrane, and perhaps even more importantly is if they start to see aortic insufficiency, they need to operate. The idea being that if they operate early, they can prevent the progressive degeneration of the valve, and they can save the patient's valve. The last thing you want to do is put in a valve in a young patient because you know that they're going to need repeated surgeries. And the rate of recurrence after surgery depends on who you read. Some studies show 0%, other studies have shown up to 20%. And of course it varies depending on which entity they're dealing with preoperatively to begin with. And there's always a risk of VSD when you resect one of these or injury to the conduction system. So I'm just going to briefly show you a few other variants of subaortic stenosis. Here we're focused on the left ventricular outflow tract. This membrane is less substantial than the one that you just saw, and it's a little bit lower. The membrane that you just saw was right up about at this level. And you can see here there's the fibrous continuity between the aortic root and the mitral annulus is called the mitral aortic intervalvular fibrosa. This membrane here actually attaches below that level and is associated with the anterior mitral valve leaflet. On this slide here, this is just another variant where the membrane is higher. It's even higher than our first variant. And the thing to note on this image is how there's not only a muscular hypertrophy of the basal septum, but there's actually a shelf that kind of undermines a portion of the aortic valve so that the left ventricular outflow tract is eccentrically oriented as it relates to the overlying aortic root. I'm getting a message to sum up here, so I'm going to proceed briskly. And this is just another example in a 2-year-old child. This is a child who had an interrupted aortic arch, and she had a VSD, so she'd had one surgery to repair that, and on echo they felt like they were seeing a subaortic membrane. And let's start with the image up here at the top. First off, the image quality here is not as good, but we did this very low dose. This was about 0.6 millisieverts for this examination for this child. And you can see here, this is shifting perspectives here. You can see that there's a small subaortic membrane, but more importantly, the aortic root itself has a small annulus, which, if you remember a few slides ago, I made reference to the fact that these were oftentimes associated with just an undersized aortic annulus. So then the question is, when do you repair this child? Well, there's no need to save her aortic valve because she has a functionally bicuspid valve down here. You can see this is the interatrial septum, so this is your non-coronary cusp of the valve here, and you have these two cusps here are fused via an intervening median raphe. So no need to save this valve. She'll need replacement at some time in the future. But she was having some symptoms and her gradient was going up. So the surgeon asked me, well, can we look at her pulmonic valve? I'd consider her for a Ross procedure. This image in the lower right-hand corner is of her pulmonic valve, and what you can see, and albeit you see it very poorly, As you can see that the pulmonic valve is actually quadricuspid and actually has a large central area of malcoaptation, and she actually had substantial pulmonic insufficiency, so that would not be a suitable donor valve in a Ross procedure. So here are some references, and I don't believe we take questions for this, but I'll be around if anybody has any questions. Thank you for your attention.
Good morning. I'll be presenting the second case of the day. Our patient was a 17-year-old Caucasian female who was transferred from an outside hospital to our institution. She presented with non-exertional chest pain without history of recent trauma. Her past medical history included migraines and asthma, but was otherwise unremarkable. Family history included coronary artery disease in the father. She was noted to be on oral contraceptive pills in singular, but no history of illicit drug use. The physical examination was largely unremarkable. The following laboratory values were yielded. She had elevated cardiac enzymes and a negative pregnancy test. Her EKG did not show an ST elevation and showed nonspecific T-wave changes in the lateral leads. Because she was presumed to have a non-ST elevation MI, she was taken to cardiac catheterization. Left ventriculogram here shows wall motion abnormality of the posterior lateral left ventricle. These are two static images from her coronary angio showing the left circumflex and the obtuse marginal branch. This image right here is just a closer view of the obtuse marginal branch. And there's a filling defect here with a subtle amount of contrast passing adjacent to this filling defect. SPECT images show perfusional abnormalities in the distribution of the left circumflex on stress images that do not completely return on the rest images consistent with a scar. This was seen both on the short axis as well as the horizontal axis. Cardiac MR demonstrates delayed hyperenhancement of the posterior lateral left ventricle here, here, and here, as well as the posterior medial papillary muscle. This CNA demonstrates wall motion abnormality of the posterior lateral left ventricle as we go through it. The differential diagnosis in this case includes coronary artery thrombus, coronary artery dissection, and intraplaque hemorrhage. The final diagnosis was a spontaneous coronary artery dissection of the obtuse marginal branch. Our patient was treated medically and no coronary intervention was performed. This is because she was not having ongoing symptoms of ischemia, as well as the fact that her disease involved a very distal and small branch, as we'll see later on in the discussion section. She was discharged with metoprolol and enalapril. So, spontaneous coronary artery dissection is a rare diagnosis with a pretty low prevalence, as you can see here. It occurs predominantly in young women with a male to female ratio of 1 to 2 and a younger age of onset with a mean age of 40. The left coronary system is more commonly involved than the right coronary system. Interestingly, the LAD is more commonly involved in females, while the right coronary system is more commonly involved in males. And 2 or more vessel involvement is seen more commonly in females, and the reasons for all of these is unknown. There is a high incidence in the peripartum period, with the majority occurring in the postpartum period, accounting for about 1/3 of the myocardial infarctions that are seen in pregnancy. Multiparity and advanced age are risk factors. With regards to clinical presentations, these patients are usually younger than those with coronary atherosclerosis. They usually have absent coronary risk factors. They can present anywhere between with acute coronary syndrome to sudden cardiac death, arrhythmias, or heart failure. Their chest pain is typically less severe and of longer duration. With regards to the imaging findings, there are a variety of imaging modalities that can be used to evaluate a larger proximal vessel that's involved. Conventional angiogram will show you the radiolucent intimal tear. Occasionally, the only thing that you'll see on cardiac catheterization is a narrowed lumen, and that's because the false lumen is thrombosed. Or the other cases will be in which you have an entry point of the dissection but no exit point, or the dissection involves the adventitia in the media and not the intima in the media. The cardiac gated CT will demonstrate the intimal flap as well as contrast within the true and false lumen. If you have a non-thrombosed false lumen, the Hounsfield units should be the same between both the true lumen and the false lumen, allowing distinction from a calcified plaque. TEE will show the intimal flap as a linear focus of echogenicity, and the color Doppler will distinguish the true and false lumen. The intravascular ultrasound, again, will confirm the presence of the intimal flap, and in those cases where you have only a narrowed segment on coronary angio, the IV ultrasound is of great clinical utility. Again, it can distinguish the thrombus within the false lumen. MR will show the regional wall motion abnormalities and cardiac edema, and SPECT will show the regional perfusion and wall motion abnormalities. With regards to pathogenesis, there's a lot of hypotheses. Perhaps the most commonly accepted is that you have an intramural hemorrhage into the media of the arterial wall that creates a false lumen. Subsequently, you'll have expansion of this hemorrhage, and that leads to compression of the true lumen, which obstructs blood flow, leading to ischemia, then infarction, and even sometimes sudden cardiac death. The cause of that hemorrhage is unknown. Some say it could be disruption of the vasa vasorum. Another common association with these cases is pregnancy and oral contraceptive use. It is thought that the hormonal and hemodynamic changes during these states lead to a structural change in the arterial wall. The increased progesterone will lead to degeneration of collagen fibers, fragmented reticulin fibers, and disruption of the normal pattern of elastic fibers. Additionally, because of the high cardiac output, decreased total peripheral resistance in pregnancy, those hemodynamic changes are also implemented. Cocaine abuse is also reported. It is thought that the vasoconstriction leads to a shear force that damages the endothelium. And angiitis leads to an infiltration of eosinophils, which release damaging proteases. There are several other associations and predisposition conditions that have been reported in the literature, and there are several case series that are listed here. With regards to treatment, the treatment will depend on the patient's underlying etiology for the dissection, as well as the morphology of the lesion. If the patient is known to have a spontaneous coronary artery dissection at catheterization, then you should see if the patient fits one of these categories. If the patient's asymptomatic, or if a small vessel is involved, such as in our case, or if the patient's case is not amenable to intervention, i.e. the dissection involves a long segment, then medical therapy is indicated and patients actually do pretty well. If, however, the patient has ongoing ischemia, a large vessel is involved, or if there's a dissection of the left main or multi-vessel involvement, then percutaneous coronary intervention and/or surgery is indicated. With regards to prognosis, about 60 to 80% of these cases lead to sudden cardiac death. About 50% will actually redissect within the same or second vessel. Complications include pseudoaneurysm of the vessel involved or propagation of the dissection. However, patients who survive the initial event do have a good prognosis. Again, we present a case of a 17-year-old female with spontaneous coronary dissection.
Pulmonary hypertension, as you all know, is a progressive disorder where abnormal elevated blood pressure in the pulmonary circulation leads to, over the time, increased vascular resistance and vascular remodeling. In the assessment of the pulmonary hypertension severity, various factors or parameters which are evaluated include clinical features, symptoms, and physical examination, the functional classification, and the 6-minute walk tolerance, exercise tolerance, in addition to various hemodynamics and right ventricular function parameters. As we all know, the Doppler echocardiography is the first line of imaging modality which is used to diagnose and further evaluate the right ventricular structure and function, as well as its presence of any pulmonary arterial pressure from the secondary features. However, to diagnose the pulmonary artery hypertension, you have to have the pressures which are only done with the right heart catheterization, which is considered the gold standard at this time. There are various studies, and this is one of the studies which show that there is a discrepancy between the echo parameters and right heart catheterization. As you can see, there is estimation or underestimation of the echocardiographic parameters in comparison to the right heart. So as we all know that the CT is very commonly or a routinely done procedure in these patients to exclude the other associated cardiac or lung abnormalities, and we thought, why not we evaluate the pulmonary arteries in this case? So the purpose of this case study was to evaluate the pulmonary artery distensibility and right ventricular outflow wall motion in those patients who had a gated EKG CT in the patients with known pulmonary artery hypertension. We also evaluated the relationship of all these parameters along with the right heart catheterization data. We selected two groups of population from our cardiac CT database. The group A was 25 patients who underwent gated cardiac CT for reasons other than pulmonary hypertension. And all these patients did not have any clinical or echo or whenever right heart cath was available evidence of pulmonary hypertension. In all these patients, echo was present, and there was no other features to suggest pulmonary hypertension. There was no valvular abnormalities, and in 3 patients, there was a right heart cath, and there was a normal pulmonary artery pressure. The second group was 40 patients who were referred and have proven pulmonary hypertension on right heart cath, and they underwent cardiac gated study. And we divided these into 2 basic categories. Group 1, this is based on the WHO classification. Group 1 is the pulmonary arterial hypertension group, which comprised 24 patients, and all other groups were lumped into the second category, which comprised 16 patients. This is the severity of the pulmonary hypertension in all these second group, and you can see the majority of the patient had moderate to severe pulmonary hypertension based on the right heart catheter mean pulmonary artery pressures. The cardiac CT was done in standard coronary artery CT protocol. We all know about that, and the only difference was the slice thickness was thicker and no medications, either nitroglycerin or beta blockers, were given. The imaging processing was done with all 10 phases of the cardiac cycle. It was processed on a thin client, and end systole and diastolic images were selected based on the short and long axis of the left ventricle. And here is the evaluation of the pulmonary arteries. The main pulmonary artery diameter as well as the areas were calculated using the double oblique methods at the end systole and the end diastole. Here is the image of the end diastole and the end systole. These were manually processed. These are the examples of the left pulmonary artery and the right pulmonary artery. The left pulmonary artery and the right pulmonary artery determination was made from the branching point to the first upper lobe branch, so the measurements were made at the middle of those areas. The right ventricular wall outflow thickness was measured on the sagittal oblique image, where you can see nicely the outflow track, and it was approximately 1 centimeter below the pulmonic valve, which is faintly visualized in the diastolic phase. The pulmonary artery distensibility was calculated using this formula, end systolic area minus end diastolic area divided by end systolic area. The mean values among groups were compared, and in the group B, those patients who had pulmonary hypertension, correlation of these CT metrics was done along with right heart catheterization data. So this slide summarizes the results. Here is the main pulmonary artery distensibility. The distensibility of the main pulmonary artery in group A, which is a normal group, was 11.8%. In comparison, patients who have pulmonary hypertension, it was 9.12%. The right pulmonary artery distensibility was in normal group 16.6%, whereas it was 11.1%. Similarly, the left pulmonary artery was 13.1 in normal and 8.52 in the patient with pulmonary hypertension. The most significant finding which we found was the diastolic right ventricular outflow wall thickness, which was 3.2 in the normal group and approximately 5 millimeter in the pulmonary hypertension group. When we looked at the p-values, only these 3 parameters had a significant p-value. So the right pulmonary artery, left pulmonary artery distensibility, and right ventricular outflow tract wall thickness. When we correlate the analysis with the right heart catheterization data, we found that the pulmonary artery distensibility has a inversely related correlation with the severity of the pulmonary hypertension as well as pulmonary vascular resistance. So as the severity of the pulmonary vascular resistance increases, the pulmonary artery distensibility decreases. On the other hand, there was a positive correlation with all 3 parameters, the pulmonary vascular resistance, pulmonary artery hypertension severity, as well as mean pulmonary artery pressure. That means that as the pressure or the mean artery pressure or severity increases, the right ventricular outflow tract also thickens. The most significant finding which we found was with the mean pulmonary artery pressure. Interestingly, in the second group of the pulmonary hypertension, the other groups were other than pulmonary arterial hypertension, we did not find much correlation with the cardiac CT parameters as well as the right heart catheterization. Now that could be a problem because we have a very heterogeneous group of population in that group and the numbers are very small. So probably we need a bigger study to evaluate this feature. And interestingly enough, the mean pulmonary artery pressure and the right ventricular outflow wall thickness was even higher in the first group of those patients who have pulmonary arterial hypertension. So here is the patient with the normal pulmonary arteries and a normal wall thickness. And here is the patient who has a severely distended pulmonary arteries and a significantly thickened pulmonary artery, right ventricular outflow tract. So in conclusion, pulmonary artery distensibility is significantly decreased in patients with pulmonary hypertension. The diastolic right ventricular outflow tract wall thickness is significantly increased in pulmonary hypertension, and there's a very strong correlation of the diastolic right ventricular outflow wall with the mean pulmonary artery pressures.
So the ductus arteriosus, as you all know, is a normal fetal structure which allows blood to bypass the fetal lungs in utero by shunting blood from the left pulmonary artery to the descending thoracic aorta, which you can see here. The ligamentum arteriosum is a vestigial remnant of the ductus arteriosus, which is a vascular structure you can see here is attaching to the inferior surface of the aortic arch and the superior surface of the pulmonary trunk. To our knowledge, the visualization of the ductus remnant has not been described in imaging literature. Therefore, the purpose of our study was to evaluate the frequency of visualization of the ductal remnant on routine thoracic CT, as well as to analyze the different factors, both related to CT technique, as well as the patient, which correspond to a higher rate of visualization of the ductus remnant. So our project was to prospectively look at 516 sequential CTs in the adult and pediatric population performed at our institution. All of these examinations were performed on a 16 or 64 slice multi-detector CT with recons of 1 or 3 millimeters. All of these images were interpreted by the attending radiologists with 10 or 13 years of experience respectively, and all of these studies were looked at in terms of patient age, gender, the slice thickness of the scan, as well as the presence of intravenous contrast. The data was collected and analyzed by myself in conjunction with a statistician. So these studies were done in 516 different patients, all of which were done at our institution. 391 of these were contrast-enhanced CTs, which were done either at 1 or 3 millimeter thicknesses, and the remaining 125 were done at 3 millimeter thicknesses, all of which were non-enhanced. Our patient age range was between 3 months and 102 years, with a mean age of 57.8 years. There were 53% of the population of our studies were in females, and the remaining 47% males. So in terms of our findings, we were able to determine that the rate of visualization of the ductal remnant on routine CT overall is 27.2%. Of those, 58% were calcified. And here's an example of one, which you can see here by the arrow pointing to a focal area of calcification in the region of the ductus arteriosus. And another example where you can actually see a vascular communication from the anterior aspect of the thoracic aorta connecting to the left pulmonary artery. Looking at specifically the factors related to CT scan, the presence of intravenous contrast did not seem to be a significant factor for visualization. This may have been due to the fact that we had a small sample size. Another example of an anterior ductal remnant seen. In terms of slice thickness, there was a higher correlation of visualizing the ductal remnant on 1 millimeter thickness scans as opposed to 3 millimeter, which was respectively seen to be 36% versus 23%. Another example where you can see a very nice communication. You can see a nice thin channel of contrast communicating. And here's another area of calcification. When looking at the patient factors specifically, there was definitely a higher prevalence amongst females to see the ductal remnant. However, it should be noted that there was a larger number of PE studies which were done at 1 millimeter thicknesses done in that population. So this could be a confounding factor. When looking at age, there was definitely a higher peak incidence between the ages of 30 and 60 years. Once again, this may be due to the fact that we were doing a higher number of 1 millimeter CT studies done in that population for PE evaluation. When looking at specifically differences among seeing the calcified and non-calcified types of ductal remnants, none of the factors seem to be statistically significant. We did see a trend, which I will get back to later, but in terms of seeing calcified remnants on non-enhanced CTs, there was a trend, but we were not able to find it the p-value was not less than 0.5. So in summary, overall, the overall frequency of which the ductal remnant was visualized in our series was 27.5%. Of these, 58% were calcified. Therefore, we concluded that if a ductal remnant is seen, it is more likely to be calcified. There is overall greater frequency in visualization amongst females with an incidence of 31.3% compared to 23% in males. However, this was a potential confounding factor because there are more 1 millimeter thickness studies done in females below the age of 50 for PE evaluation. There was an overall 35% increased relative risk of visualizing the ductal remnant on a 1 millimeter thickness CT image when compared to a 3 millimeter image. As we discussed, there was a peak incidence between the ages of 30 and 60. However, again, because of the 1 millimeter thickness studies done in that age group, this could be a potential confounding factor. The presence of contrast did not seem to be a significant factor in visualization. specifically looking at ductal remnant calcifications, there was no significant difference in frequency when comparing gender, age, or slice thickness. However, there was a trend, as I said before, that we did see a trend of seeing more calcified remnants on non-enhanced CTs. And when looking at non-calcified remnants, they were seen as very thin vascular channels, usually containing contrast between the region of the aortic arch and the left pulmonary artery. Our limitations included that this was a prospective series. There was not and could not be an independent reference standard. There was no assessment of inter-observer attending radiologist agreement, and we were not able to compare contrast-enhanced and non-contrast-enhanced CTs in the same group of patients. So in conclusion, the remnant of the ductus arteriosus are a frequently encountered finding on both enhanced and non-enhanced thoracic CTs. The high incidence of these findings on routine CT likely reflects the increased spatial resolution of our current CT technology, combined with the increased radiologist awareness in our study. And therefore, radiologists should be aware of this phenomenon to avoid confusing them with pathologic processes, such as aortic injury in trauma patients or thoracic aortic atherosclerotic disease.
We all know that the coronary artery imaging with MDCT is an accepted, non-invasive method to image the coronary arteries routinely. These images are acquired from the level of the carina through the base of the heart. In addition to imaging the heart and the coronary arteries, partly the great vessels, portions of the lung, mediastinum, and also parts of spine and chest wall are imaged. Additional information from the chest, neck base, and upper abdomen included on the topogram images is usually not incorporated in the final reconstructed axial CT images. So we went ahead and did the study with an aim to retrospectively review the topogram images from the coronary CTA examination with respect to the extracardiac findings and assess their clinical significance. We reviewed 776 consecutive patients. The exclusion criteria were the patients where the topograms were unavailable, or a different scan protocol was used, as in patients with history of prior CABG, cardiac transplantation, or coronary artery reimplantation. A few patients had repeat studies, so after exclusion, it gave us a final number of 656 patients. The electronic medical records were reviewed, and basic data like age, gender, clinical indications, smoking history, past history of malignancy, and a brief surgical history was taken. The surgical history was particularly taken to exclude the aforementioned patients with history of thoracic surgery because they were to be excluded. All the imaging was performed on a 64-row CT scanner at our institution, and the images were reviewed by a senior staff radiologist and 2 radiology residents in consensus. We noted all the extracardiac findings, and then went ahead and classified our data into significant findings and the less relevant findings. So to interpret the images, all the reviewers created an imaginary field of view here. They marked from the level of carina to the base of the heart, and also the lateralmost aspects of the cardiac contours. Any of the findings which were found outside this realm of imaginary field were considered as extracardiac findings. There were significant findings which we thought impacted the patient care significantly and required either a follow-up imaging protocol or immediate clinical intervention. These were like pulmonary nodules, consolidation, and the less relevant findings were the ones which did not require immediate clinical intervention, like emphysema, healed fractures, incidental finding of substernal thyroid, and so on. Just to mention here, whenever we found a pulmonary nodule, we went back and retrospectively reviewed the patient's chart again to review if there was correlation of past history of known lung carcinoma. Of the 656 total patients, the mean age was 53.3, and we had more males on our study, comprising of 59.8% of the total population. We also noted cardiomegaly in 79% in 79 patients, but it was presumed to be noted and reported on the cardiac portion of the CTA study. The table 1 represents here the patient data, which showed that 16.6% of our patients were current smokers, and 11.3% of them had known malignancy history of various types of cancers like skin, breast, prostate, gastric, lung, and so on. Coming to the significant findings, 55 of our patients had 60 significant findings, comprising 8.4%. Of note, the pulmonary nodules and pleural effusion comprised of the largest populations, and other significant findings being aortic aneurysm, pulmonary consolidation, mediastinal adenopathy, mediastinal widening, a few cases of pulmonary hypertension and herniation. The less relevant findings were found in 82 patients, which were 12.5% of the patients. And these were findings like aortic atherosclerosis, musculoskeletal findings like scoliosis and healed rib fractures or clavicular fractures, other lung findings like parenchymal scars, emphysema, pulmonary fibrosis, calcified lymph nodes, and a few abdominal findings like abdominal surgical clips or even a pleural plaque in a case. I'm going to show a few cases. Like here we see this patient has a right mid-lung nodule, which was excluded from the realms of the reconstruction of the coronary CTA. Another patient with a right hilar mass, and on retrospective review of this patient's chart, it was found to have pulmonary adenocarcinoma. Another patient with the blunting of both costophrenic angles, showing bilateral pleural effusions, again outside our imaginary field of view for the reconstruction of coronary CTA. Here is a case of a patient with right lower lobe consolidation, and I've put up a CT picture follow-up next to it, which confirmed the presence of right lower lobe pneumonia. A few cases of patients with bilateral and hilar lymphadenopathy. On review, these patients had history of sarcoidosis, and these were incidentally noted on the topogram images. Here's a patient with emphysematous changes noted in both the lungs, but this is again outside the limited field of view. In our study, 20.9% of the patients had extracardiac findings. Of these, 8.4% had significant findings. We know that prior studies have been done to evaluate the extra